The bitemporal hemianopia was classically described with chiasmal lesion due to compression of the nasal field or decussating nasal fibers on the chiasm. So this will lead to the bitemporal hemianopia. However, you may be surprised to know that the bitemporal hemianopia is not the commonest neurological disorder, or is not the commonest visual field defect to occur the chiasmal syndrome. But there are other manifestations or other presentations to the chiasmal lesion. Let's see. First, you may not find a bitemporal hemianopia that is symmetrical, but you can find a bitemporal hemianopia that is more dense superiorly, as you can see here. This is a bitemporal hemianopia that is more dense superiorly, and this is because of a compression from below caused by pituitary adenoma. So it will compress the optic chiasm from below, leading to starting superiorly or starting bitemporal hemianopia superiorly. The reverse occur in cases of craniopharyngioma. For craniopharyngioma, compression occur from above. This will lead to bitemporal hemianopia that is starting inferiorly. So sometimes in the exam, on the first instance, when you see this picture, you jump to diagnosis of quadrantanopia. But please note that this is bitemporal, not homonymous contralateral. So please concentrate. If it is in the nasal field of one eye and the temporal field of other eye, so this is a contralateral homonymous quadrantanopia. But in this condition, it is bitemporal in both sides. Other presentation is the junctional scotoma. In the junctional scotoma, there is a lesion compressing the junction between the optic chiasm and the optic nerve. So it will lead to involvement of the central fibers of the ipsilateral eye, as we can see here in the left eye, leading to central scotoma. And the involvement of the decussating nasal fibers from the other eye, leading to temporal hemianopia of the other eye. So this is the case of junctional scotoma. If the lesion starts to enlarge furthermore, this will lead to what's called hemichiasmal defect. So in hemichiasmal defect, there is involvement of the optic nerve on the same side, optic tract on the same side. That's why it can lead to up to blindness of the one eye. So there is the side of the lesion, the eye is completely blind. And it involves the decussating nasal fiber from the other eye, leading to starting temporal hemianopia of the other eye. That's why it's called hemichiasmal defect, because there is hemianopic lesion on one eye and blindness on the other eye. So this is also a very important presentation of the chiasmal syndrome. Another presentation is involvement of the posterior chiasm. The posterior chiasm, there is macular fibers decussate in the posterior part of the chiasm. So if the lesion compressing the chiasm from posteriorly, this will lead to bitemporal hemianopia, but at the level of the macular fibers only. So it will be central bitemporal hemianopia. So these are all the presentation of the chiasmal visual field defect. Let's summarize them here. If a lesion cut the optic nerve at all, it will lead to anopia, so there will be no vision at all. Lesion at 2 will lead to a junctional scotoma, meaning that it can start first with the affection of the central fibers. So it will be either central scotoma in one eye and temporal hemianopia in the other eye, or with progressive involvement, this will lead to hemichiasmal disorder or hemichiasmal affection, which meaning that there is involvement of the whole optic nerve and the decussating nasal fiber, and they can also extend to the ipsilateral optic tract. At the chiasm, at number 3, if in the central in the chiasm and symmetrical, it will lead to bitemporal hemianopia, and as we said, this is not a very common presentation. In the posterior chiasm, this will lead to central bitemporal hemianopia, and for the optic tract, it will lead to affection of the ipsilateral temporal fibers and the decussating nasal fibers. This will lead to contralateral homonymous hemianopia, as we will see now.